Good evening, everyone. I am Dr. Johnson. I'm one of the neurosurgery house officers at Port Spain General, and today I'll be giving a brief presentation on the anatomy and physiology of CSF. So a lot of the content today will be from basic sciences, but understanding the basic concepts really gives an ease of identifying and diagnosing conditions that we see regularly, right? So we start with a definition of cerebrospinal fluid. Essentially, it's a clear, colorless liquid. It's an ultrafiltrate of the plasma that bathes the CNS, so the brain and the spinal cord. This is found in the subarachnoid space, which is the space between the arachnoid membrane and the pia mater. And we usually have an average of 150 mils of CSF volume at any one point in time, with 25 mils being attributed to the ventricles and 125 in the subarachnoid spaces. The CSF functions similarly to blood, but differs in composition of electrolytes, glucose, and protein content. So we're going to touch a little bit about CSF development. Embryonic CSF is located in the cavity of the anterior part of the neural tube. So going back to early basic sciences, where we learn about the forebrain, midbrain, and hindbrain. The forebrain is where the embryonic CSF is located. This forebrain is surrounded by neuroepithelial precursors. So these are non-specific cells that don't have any sort of basic composition, and they don't appear to circulate, right? They start at 4 weeks. The process of neurulation starts, which is basically the neural plate forms the ectoderm and the neural tube, which then form the brain and spinal cord. The end of the embryonic CSF period is marked by two processes. The first is the appearance of the choroid plexus, which is now the center of CSF production, and the opening of the rhomboencalaphic roof, where the subarachnoid space would be developed. Together, they make a closed cavity system where the brain where the CSF and the neuroepithelium can function interdependently. So despite changes in blood composition and flow, the composition of CSF is kept constant, which provides a stable intraventricular environment critical for maintaining normal neuronal function. This is just a diagram breaking down the composition of the CSF. So CSF contains blood proteins such as albumin for protein transfer, immunoglobulins, leptin, which is multifunctional, and prolactin. Vitamins for all its metabolic processes, so ascorbic acid, folate, thiamine, monophosphate, pyridoxal, and riboflavin. Ions that create electric channels, so sodium chloride, bicarb, potassium, calcium, manganese, and magnesium. And the protein synthesized in the choroid plexus, which are transferrin, IGF-2, and BDNF. So the transferrin is a glycoprotein for iron delivery, specifically the IGF-2. This is insulin growth-like factor for growth and development, and the BDNF is brain-derived neurotropic factors. These are essentially act as a neurotransmitter modulator, and they assist with neuroplasticity, so they are for learning and memory. So this is just a comparison of components in the CSF compared to blood plasma. So CSF contains little to no protein compared to blood plasma, about half the sugars that we can see, and comparatively about half the amino acids, right? With regards to ions, the sodium is about equal. The potassium is about half of the amount of the blood plasma, and that is to maintain homeostasis. So this chart gives a touch on the pathology. We're not straying too far there, but understanding the normal CSF composition can give us an idea of what we are dealing with regards to pathology in a patient. So if we get a sample that has a significantly increased protein, we can think of bacterial infection. If we also see something like a decreased glucose to serum ratio, those are predominantly bacterial infections. But if we have grossly bloody samples with xanthochromia, we can think of subarachnoid hemorrhage. So the physiology will be broken down to production, function, reabsorption, and regulation. So back to the choroid plexus, this is a network of fenestrated capillaries that allow filtration of the plasma. They align with epithelium cells that are called modified ependymal cells. And the choroid plexus has dense microvilli that present to the apical surface. So their cells have interconnected tight junctions, creating the blood CSF barrier that helps control the composition of CSF. So this is just a diagram of the blood-brain barrier that is formed. So larger substances such as cells, proteins, and glucose are not allowed passage, whereas ions and small molecules can freely go through. Water is allowed passage through the aquaporin 1 channels, also via the osmotic gradient that is created by the positive voltage potential created from the electrical charge pulled by the sodium chloride and bicarb ions. So this is just a quick illustration of the flow of CSF. So it's created by the choroid plexus and flows into the lateral ventricles via the intraventricular foramen of Monroe. It goes to the third ventricle, through the cerebral aqueduct, and to the fourth ventricle, through the median and lateral aperture, aka the foramen of Lishka and Majondi, to the subarachnoid space, and then to the superior sagittal sinus. So this flow is propelled by the systolic pulse wave of the choroid arteries. Lesser determinants of CSF flow are respiration, posture, venous pressure of the jugular vein, physical effort of the individual, and the time of day. So CSF functions, the first function is protection. And so CSF provides a hydromechanical protection of the neural axis. It acts as a shock absorber by cushioning the brain against the skull during trauma, and provides buoyancy by reducing the weight. The average weight of the brain is about 1,500 grams. So with the CSF, it reduces the weight to about 50 grams. So therefore decreasing the force of the parenchyma and vessels during injury. Another function is nourishment. The main conduit of nutrition supply of the brain is the ECSB nexus. And so the transport of substrates that are needed through the CSF diffuse into the ECSB for transportation to their sites of action within the brain. And the final function is waste removal. So the removal of brain metabolism, waste products such as perioxidation products, glycosylated proteins, excessive neurotransmitters, debris from the lining of the ventricles, bacteria and viruses, and otherwise unnecessary molecules. So CSF reabsorption, the arachnoid villi are protrusions through the arachnoid matter, through the dura mater, through the lumen of the venous sinus, right? It leaves the subarachnoid space through the arachnoid villi along the superior sagittal venous sinus, the intracranial venous sinuses, and along the roots of the spinal nerves. They may also leave through the lymphatic system via the nasal cribriform plate or the spinal nerve roots, and is also dependent on the posture of the individual, pressure differentials, and pathophysiology. So the cranium is a rigid structure that contains the brain, CSF, and blood. So any increase in the volume of any of the contents would increase the pressure of the cranial vault. The normal intracranial pressure of adults is 6 to 25 millimeters of water, or 10 to 15 millimeters of mercury. So without touching on the pathology, any form of CSF dysregulation can cause increased intracranial pressure, such as the overproduction of CSF, under reabsorption, infections, trocar hemorrhage, and space-occupying lesions. We're going to touch a little bit on lumbar puncture. We are all aware of the procedure. It's a sterile spinal needle that's inserted at the level of L3, L4 into the subarachnoid space to attain CSF. Xanthochromia, as I mentioned earlier, is a yellow-orange discoloration of our CSF caused by the breakdown of red blood cells, usually indicative of a subarachnoid hemorrhage. Elevations of concentrations of immunoglobulins, oligoclonal bands, may indicate systemic infection or an autoimmune disease. Traumatic taps. So traumatic taps are where peripheral blood is introduced to the CSF during a lumbar puncture. With a traumatic tap, you see an increase in both white blood cell and red blood cells. So differentiating, so there are multiple methods that people have used to differentiate a traumatic tap from an infectious source. Most widely used is a white blood cell to red blood cell ratio of less than 1 to 1,000. So basically, you get the predicted number of white cells and minus it from the observed number of white cells. If there's an excessive number, we can likely think it's an infectious source versus a traumatic tap. Some physicians used to collect 3 samples by counting the red cells in the consecutive tubes to determine if there's a decrease in the number of red cells. And another method is to centrifuge the CSF and look for xanthochromia, which would likely lead to subarachnoid. All of this needs to be taken into consideration, the clinical and laboratory findings of the patient before opting not to treat. And last but not least, we have a CSF leak. This is where a CSF escapes through the tear or hole in the dura. So spontaneous CSF leaks can occur due to increased intracranial pressure. This can also occur due to head injury or surgical procedures involving the sinuses or brain or spine. Or there can be iatrogenic damage via lumbar puncture. So this is where we use the transferrin, beta-2 transferrin specifically, which is a protein produced by neuraminidase activity in the brain, which is uniquely found in the CSF and the perilymph. The absence in the other body secretions confirms that it is a CSF leak. So I've come to the end of my presentation. Does anyone have any questions or